particular kind of pain relief drugs I should take. That is one. Then two, my NHIS that year, though I've not used it before, ever. They said it was NISA Premium, So though I called them this evening and was told that yes, that those tests are covered if they are my NHIS is supposed to pay for them rather. So as it stands, I don't really know if people call know how this NHIS thing works or the NHIA thing works, yeah. And or maybe if there's a contact who I should talk to where they can, make the process a bit more seamless. Because I have my NHIS number, but like I said, I have never I don't fall sick like that, so I've never ever had any reason to use the services here.
Okay, yes. NHIS pretty much covers most of these tests. In some hospitals, you don't even have to pay for anything. Just go and then with your NHIS number, they'll write tests for you, get it done and all that. I think NHIS is 50%. So there are tests like BCG, something that NHIS can cover. So you go to your hospital, the hospital where you are registered to, I think they can attend to you. So that will be fine. Now as for the pain relief, basically you can use any pain relief, but you can use any pain relief as long as the only pain relief you should be wary of is maybe if you have ulcer like we discussed the last time and you're trying to use any of the NSAIDs, that's where you will wary. But any pain relief can work, even paracetamol can work at this point, for your pain, and the pain relief depends on the severity of the pain. If the pain is not so severe, if you tell me the count from 1 to 10, how severe is the pain? So I know. How severe is the pain for 1 to
10? Maybe 5, 6. Though it's periodic, yeah. If I'm walking around doing my stuff, it doesn't come until when I try to lie down, because in fact, initially when I had the impact, I used to put use 2 pillows to sleep together, because if I lie down flat, I'll feel the pain. So I had to incline my head a little for me not to feel the pain. But in recent times, I've started sleeping on just 1 pillow and all of that. But if I try to turn...
How long has this pain been? How long?
Just a week from the impact, a week.
Excuse me. A week now. Okay,
yes,
it's okay.
Please.
A week is not so bad. So just give it time. It's going to go. Just take your pain relief whenever you feel the pain is worse. And then you can use paracetamol. Doesn't have to be very high pain. Just paracetamol can do that.
Okay.
Do that. So no need to go for
that's
very high.
500 mg.
Yeah, 1 gram. 1 gram, that's tablet. You can do it.
Okay. Okay.
So that's really help out because pain. It's not a very severe pain.
Okay.
So
it's all right.
If you feel that maybe the place is weary or maybe a bit swollen, then you can visit somebody to examine you, maybe the hospital.
No, it's not swollen. It's not swollen. I was just, at this, especially the age they go, we need to, take something a bit more seriously, So, as the person said, have an enlarged heart. Though, of course, I know I don't, but of course, it's just to check for optimum functionality of, some organs. Yeah.
Yeah. Basically, if I had seen a patient that came to my clinic and said, "Oh, I have an enlarged," they told me that I have an enlarged heart. First thing I'll ask the person, which is the common thing, is, are you hypertensive?
Yeah, of course. No, I made a research also and was told that was one of the major causes. Although, in fact, they even gave me some some technical terms, cardiomegaly or something, and all of that.
Yeah, that's the
thing. And that's what the radiographer put on his report. That I have cardiomegaly. So when I went to a bigger and better lab, they said that's not true.
Yeah.
So those inconsistencies, says a lot about, a lot of, but that I talk for another day.
A radiography is not supposed to make a diagnosis per se. You understand? They are
Okay.
supposed to just do the X-ray and give it to you to give your doctor to interpret. You understand?
Okay.
A radiographer has no right to be making an impression or diagnosis because sometimes many of them don't know exactly how we measure these things, and sometimes some of them don't even know how to do those X-rays. There are some angles at which you do the X-ray, the heart may appear enlarged. You get what
That's
I'm saying?
LP and AP and all of that now.
Yeah, there's a way that they will not position you properly, and your heart will appear enlarged. You get
Okay.
so, and then sometimes machine error. The machine may have mentioned that, sometimes some machines are programmed to mention some things, and then the person will just impressions cardiomegaly. They're not supposed to make impressions. They're just supposed to do the investigation and pass it on to the doctor to give their
Okay.
impression based on based on your clinical findings, based on the examination findings and the questions that they have asked you, and then tie it down with the clinical findings, to actually make a diagnosis. Diagnosis is not just made by just doing tests. You have to tie everything together. Yes, so
Okay.
that's I think that should be enough to clarify. Okay.
Okay. It's all right. Thank you so much.
Yeah. So any other questions? Feel free to ask your questions. Chat room is there. Type or you can always send your questions on the chat box. General medical questions doesn't have to be related to any specific area. Just general questions, and we'll answer it. Thank you as we await your questions.
Yes. Also, now that we're here, since nobody's talking, I think I have another question also too. So, in the course of this, also, my brother, for some reason, um, told me to take ibuprofen and paracetamol. So on the first day, I took together, although I later learned that it's not a very right thing to do. I took PCM 1 gram and ibuprofen 400 at the same time. So I'm just wondering if it's actually an issue or if it's okay to take them both, because of the severity of the pain. And if they are, if they have like the drug interactions and all of, because someone's even saying me that they do different things. That's why you could take them together. So I just need a bit more clarity on that. Thank you.
Now, ibuprofen is a pain relief. Paracetamol is a pain relief. They are both in the same category as pain relief you can use for mild um, mild pain, mild to moderate pain. Yeah. So they act by different mechanisms. You understand? Two of them act by different mechanisms. Me, as a doctor, I will never prescribe paracetamol and ibuprofen to be taken at the same time. Instead of having you take them at the same time, I'll prefer you take, but it's your pain.
We didn't hear you. We didn't hear you, please. If before we
Using
take,
two
that's where you started breaking.
analgesics. You understand? I'll be thinking of the severity of prescribing. Two of them do not interact, as in there's no of them at the same time. So nothing will happen to you. It's not wise to actually prescribe two at the same time. You understand? Pain will do, paracetamol will also can also do it. You get, so that's it.
Okay, thank you very much.
You still want more clarification?
I would not mind, if I'm being honest.
Okay, what aspect do you want more clarification on?
You talk because at some point you were breaking, so I could barely even hear when you said unless
Huh?
the US, you were breaking at
Hello?
some points. Can you hear me?
Okay, let me repeat myself. Okay, I'll say it
Yes,
again,
please.
okay?
Okay.
Paracetamol is used for mild to moderate pain. Ibuprofen is also used for mild to moderate pain. You understand? Both of them have different mechanism of action, but in all, they are both pain relief. You get
Oh, okay.
different action. Why ibuprofen works by a different,
But they still end up doing the same thing, I guess.
you
Not
understand,
different
to
things.
reduce pain. Yes. You understand? So me as a doctor, I will not prescribe the two of them at the same time.
Oh, okay.
Mild to moderate pain, except maybe the severity of the pain is more, and maybe I had given paracetamol, did not really do anything, never said so. I gave her still in pain. Okay, let me give ibuprofen, that kind of thing. But I will not give them together. Not
Oh,
that
okay.
if you give them together, I will not normally give them together. Rather, if the pain is severe, those two drugs are not my. We'll go for something higher. Do you understand? Rather than using the two together, I'd rather use one of them.
Okay. Like
You
a stronger
understand?
one.
A stronger one.
Okay, fair enough. It's
So
all right. I
that's
think
the way
that
it
answers
works.
it. Yeah.
Mhm. So that's that.
Okay, thank you once again.
Yeah. Question in the chat room. I think one of those questions we've answered it before. I think I've thrown more light to it before, but I will still answer it. Does CS? The question is, does anything to do with back pain for women after CS? Now, I think the last time we had this Q&A session, so just touch on this, and he mentioned that okay, yeah, if there was a complication, during spinal anesthesia, you understand, when they gave that, if it was spinal anesthesia they used for the CS, and maybe the person did not, maybe there was a complication while giving spinal anesthesia, we could relate the CS to back pain. Okay, you know, that's one. Now, number two is after child, your hip and pelvis has expanded. The pelvis expanded because of the childbirth. Okay, so after childbirth, there has to be some some lifestyle change for everything to really return back to normal. You understand? Now, but in our African setting, there are so many things, and there are so many things we practice that actually help our back pain to worsen rather than getting better. Now, one of the practices is carrying the child on the body. You understand? Yes, that carrying the child on the body, standing for too long. Another practice is bending down, maybe to wash baby's clothes. bending down to cook, bending down to do house chores, even after you've just given birth and all those stuff, you know, all those things that come with motherhood. I think your baby, you bend down, all those things will accumulate and make you make it look like, oh, after CS or after I had a child, I've been having back pain consistently. You understand? So my advice is we should be very, very, very cautious on the way we take care of our back, especially after childbirth. Because as women, our whole skeleton goes through a lot of process. During pregnancy, the weight of that carrying that baby in your tummy impacted on your back. Now you have given birth, and everything has to go back normal. Do things out, as in carry out practices that are healthy for our back. We are still bending to do house chores, carrying babies on our back, carrying babies on our body, stressing the back, and then the back pain just keeps going from there and then on. Before you know, the woman is having lumbar spondylosis and everything, you know. So that is why I would attribute, oh, the woman would assume that, okay, after I had the CS, my back continued paining me. Some people maybe it may not even be CS. My own series of back pain started after I gave birth to my last child. You understand? After I gave birth to my last child, it was back pain upon back pain, back upon back pain continuously. Of course, so I also did things that worsened the back pain too. So we just have to be wary and protect our back at all costs. Lifting heavy things is not healthy for our back. Bending down to do house chores, bending down to wash that baby's clothes, all those things not help for our back. Carrying our babies on the back for hours and standing and back carrying baby on back and standing and dancing is not healthy for your back. You understand? Even carrying on your body frame is not healthy for the back. So as you've just given birth, best thing for you is to use corset to hold your pelvic girdle in place. Use corset to protect your back. You know, as you are using corset to flatten your tummy, that corset can also be very, very protective to your back. So that is what I would advise. Then the second question, well, pain. Okay. Now there are 1,001 things that cause knee pain. You understand? Because the knee is one of the joints that bear your weight. It is weight bearing. You understand? And as we age, our knees have we lose their cartilages and some tendon and some structures that actually protect the knee from wear and tear. But as we age, those wear and tear become more, as in those wear and tear, just like when you buy a new shoe now, you use it as a worker. The first time you use it to walk, it's not chop. As you use that shoe, let's say use it very, very well, trekking every day. You're trekking from one point to another every day. You're trekking with that shoe. That shoe is your trekking shoe. There's no way the sole of that shoe will remain the same, right? That's the same thing for the knee. As we walk about, we do things and everything. Our knee joint goes through wear and tear because it bears a lot of your body weight. You understand? So it is very, very likely you will get pain as you age on your knees. You understand? It is very, very likely. It is the most common site for what we call osteoarthritis. The knee joint is one of the most common sites for osteoarthritis. So as you age, it's not unusual for you to start to have pain on your knee. So what can you do? The next question I would expecting us to ask is what can we do actually um, to pain, and all that. I did not talk about trekking, no. I said your knee faces wear and tear. You mustn't trek for your knee to have wear and tear. Your knee is bearing the weight of your body. So if you still wear am, as long as you are standing, you are moving about, you are whatever. Your knee is bearing your weight. So as you are aging, your knee is taking wear and tear. You understand? Just like the shoe that has been used for a long time, your knee that has been used for a long time, taking wear and tear as you age. You understand? So what you should do is if you start to have knee pain, it is expected that you should go in and get an X-ray done so that with the X-ray you'll be able to know the way to be able to help us ascertain what is the level of damage. How bad is damage to the knee. Now, if your knee is found to have to start facing wear and tear, there are other means, other methods, other things that can be put in place to ensure protect the knee those wear and tear. You understand? For example, sitting for too long and standing for too long is not good for the knee. You understand? When you sit for too long, you stand. When you stand for too long, you sit. You understand? Especially at the point where you are having a knee pain. If you're having a pain in your knee, it's just like your body telling you, you have overused me, oh, I need to rest now. When you get to that point, you're supposed to be resting that knee. But if you don't rest that knee and it keeps paining you, the next thing that will happen is that pain, the knee will swell. You understand? And the usual response that most of us do is that once our knee starts pressing it, more pain cause more inflammation, more swelling. And the pain swelling now has tightened the space. And that's how the visual section and your knee is facing more wear and tear because of the inflammation and everything. And before you know, the knee is gone and you are needing they are telling you you're needing a knee joint uh, joint replacement and all those things. You understand? So what how your knee wears and tear depends on how you manage it basically. But wear and tear is normal as you age. You understand? Depends on how you manage from the shoes you wear, from how long you sit, how long you stand, for how you care for how you care for your knee, especially when it's painful and swollen. When it's painful and swollen, you are supposed to be resting your knee. Instead, people carry sometimes is swelling to rest your knee instead of applying or trying to massage it or make it swell. Keep swelling to rest the knee when your knee is paining you. The body telling you need to rest. You understand? If you're sitting in a sit position and your knee is paining you, body is telling you, I need your I said there's tension on the knee. Stretch it down. Stretch it. If you're standing, your knee is paining you. Lie down. That knee is paining you. What else? Turn it. Keep it in position that the experiences wear and tear, and that will not be good because as in continuous progressive wear and tear will make you have make the will erode the knee joint, and you'll be needing a joint replacement, or there'll be a disfiguring of your knee joint and or your um leg positioning and all that. You see, some people have to now be using walking sticks to walk, and then they're having pain even as they grow old. So that's the thing. I don't know, Dr. Eze, do you want to add something more to what I have said? Somebody talked about, yes, before I even hand the baton to Dr. Eze, the weight gain too is another factor because, like I said, it's all about the knee bearing the weight of the body. Imagine you add so much weight now that it's more than what your knee can carry normally. You're giving that knee so much job to do because it now has to do the work of carrying this your body that has that has accumulated so much weight. You understand? So that's why you see most people who are kind of like obese, they end up having a lot of arthritis, you know, they end up having arthritis because the knee is suffering from the weight that it has to get. You understand? So that's those are the things. So I don't know. So do you have something else to add to this?
No, Mama. I think you really started that very clearly. The commonest thing around, maybe there's a CS was because of the spinal, and of course, what we usually advise women is don't be quick to start moving those spinal and vertebral column quick because of course, spinal headache and all that. And most times when
Mm.
women cooperate well for that, that thing does not happen. But when they are quick to move and also get up and start being active after having that spinal for anesthesia supply. That's when that complaint usually comes. And of course, you mentioned it also, being so fast to go back to normal routine and also, wet shedding and all that. So these are some of those things that, affect some of those pain that might linger and are very nagging, and you say. So yeah, I totally agree. I just wanted to check this.
So I hope Randy will be able to answer all your questions. Hello. I hope we've been able to answer all your questions. Any other question for us? Hello. Yeah. So somebody's asking that uh we should tell him more about prostate and breast cancer. Talk more about it. So Thursday, can you open the floor for this question so that I can fill in later?
I didn't hear you. What is it?
Okay, they asked the question about prostate cancer.
Okay. So
Yeah.
let me see. Let me see what the question is. Uh, okay. Yeah. So, but this is a very very large question, but I'd just like to summarize it. So, maybe this is more specific. But one thing is this: prostate cancer. Of course, cancers are not. There are no known causes of cancers. You know, there are no known causes of cancers. They only can only say, um, associating factors. The only cancer, of course, that we know a known cause is cervical cancer, which is caused by human papilloma virus. So if you can handle human papilloma virus, then women are safe from having cervical cancer. That's the only known cancer with a cause. Every other cancer is caused by just um, mutation, so to say, of your own body cells. That is why management of cancer is very difficult because invariably, as you are trying to handle the cancer cells, it's actually your own cells you are dealing with. So, but for prostates, what we usually advise is men above 40 years should always have PSA checks every year. So, once you hit 40 and you're celebrating big 40, oh, welcome to the fourth floor. It's time for you to also start checking what is happening down below, right? And the prostate for which it is designed is a muscular tissue, a muscular organ that is just at the neck of the bladder. So the reason why it's at the neck of the bladder gives you the idea why the commonest symptoms that comes with bladder cancer and prostate is first of all urine changes. difficulty in passing urine, hesitancy in urine, that is taking time to start urinating and all that, and say, make no mistake that is now the element of the late 60s and 70s. The reason why we say that prostate check should start from 40 years is because there have been incidences of people beginning to get it in their 30s. So causes are basically not assigned classically, but one clear cause or one clear associating factor is, of course, genetics. So if you have a father, a relation that is close to you that has had it, when I say relation, I mean your father, your brother, and that's had that prostate cancer or prostate related issues, then it's also good to watch. What are we looking for? We're looking for what we call prostate-specific antigens. I don't want to go deep into that. But the idea is that every year, of course, they are 40 and above, 35 if possible, we begin to check for PSA. And the level of PSA determines the health of the prostate. One, if the PSA is within 0 to 4, that's fine. It's okay. Anything above 4, let's say 4 to 10, we call it benign prostatic hypertrophy, which is just the normal enlargement of the prostate with age. That's what we call that. So if it is beyond that range of 4 to 10, we say it's BPH. It's a benign. There's no cancer. It's just benign growth. It's just growing because it's aging. But anything above 10, we get worried because anything above 10 is tilting towards cancer. And then if you're talking about cancer, you're not asking, is the cancer cell still within the prostate? Is the cancer cell outside the prostate but within the prostatic capsule? Then the next one asking, is the cancer outside the prostatic capsule but has not gone out of the body, out to the whole body? Or has the cancer spread to the body to, of course, through the lymph nodes? Has it spread to the backbone, to the heart, to the kidney and all that? So there are 4 stages that it really comes with. But the most important thing is to constantly check for that. When you check and you are within normal frame, fine, that's good. When you also check and it's benign, your doctor will advise you on what to do. So I say people take some supplements, some people take some medications. Those things usually come into play when of course, the cancer cells are now beginning to, when the enlargement of the prostate is beginning to have some symptomatic effects. There are some people who, before they urinate, they have to strain and strain and strain and push and push and push before urine comes out. Because, of course, the enlarged prostate has blocked the tube. That's the pipe to which urine comes out through the bladder. So it has a very close relationship to the bladder. So what I tell people at this point, because I wouldn't want to go deep into the medicals or even the treatment because we're not here to treat, but what we're here to also just awareness and advice. Please go for PSA. Please go for mammography. Women should go and check their breasts. Women should do their 4-point breast examination, as often as they can to pick out those lumps that might be present. Because when the breast cancer comes in, when the cancer cells are there, there's little or nothing science can do. It might end up like in the male treatment, they can remove the prostate, and other women, they can remove the breast, but we can do much more to prevent it from getting to that point. That's what we're saying. So when the cancer cells spread, the painful thing about people that are not very careful with checking their prostate or their breast is that they present to the hospital with advanced clinical symptoms. And those symptoms are usually symptoms of distant organs. For example, you have people complaining about bone pain, people complaining about kidney issues, people complaining about chest pains and difficulty in breathing. And by the time you start treating those symptoms, you are invariably treating the wrong thing because the issue is shooting from somewhere else. That's how cancer works. So the symptoms are usually coming from somewhere else. And then before you narrow down to the fact that, oh, this is what is causing this, the person has plus or minus 2-3 years to live. So it's important to start early. For us now, we're saying women, the breast cancer is the leading cause of the leading cancer in Africa, in Nigeria for women, followed by the cervical cancer. And then we say that women should regularly, of course, do these investigations, and men on their own side should check their PSA every year. Once you hit 35, 40, check it every year. We'll be able to advise you accordingly on things to do and meals to take, There are some non-pharmaceutical processes you can do. Not everything is not medication. Even dieting, even your lifestyle modification can help to keep some of these organs healthy and help you from tilting towards enlargement or cancer, as the case might be. But yeah, that's what I can say about that. I don't want to go beyond this point. Thank you. Another question here I see on sperm cells. It says, help us explain healthy sperm and how to get about it from face our babies. I don't understand this. Help us explain healthy sperm and how to get it before them go there. Face our babies, say them they impotent. Okay, I mean, well, very simple. Seminal fluid analysis helps to know the health of the sperm cells, just seminal fluid analysis. That's the concern for people that are having difficulty in conception, and we have discussed about that conception being unable to conceive within 1 year if you're having regular unprotected sexual intercourse. We're talking about 3 to 4 times every week consistently for a year. So when people have that issue, the next thing they go for is SFA. OG is not here to tell us more about that. That's field very well. But what we say that is that you go for SFA, and they will check and know whether there's there's quantity is enough, motility is enough, and morphology. Oh, OG is here, so I think OG can
Yeah,
give.
yeah. So that's it.
Okay, OG, please take it away.
Good evening, everybody. Good evening, Dr. Heskey and everyone. All right, you have practically said almost everything about the SFA. Now, when patient come in for SFA, we are not just checking to see if their sperm count. We are checking to see, is there motility, is there viability, how is the morphology, how is the progression? Because some people actually confuse having sperm that is motile with maybe you go for SFA and they say sperm count 100 million, motility 50%, and you say you are okay. But what is the progression of the sperm? A sperm can be motile and just be in a particular place moving. It's just like you are going from Wuse to Gwagwalada. It's just one way. Take a bus along from Berger straight to Gwagwalada. But instead, you will first take taxi from Wuse, you go to Area 1, then come back to Berger, then go to Mabuchi, then come back. At the end, you don't get to Gwagwalada. You are just rigmaroling in one place. So when people see that, they say their sperm is motile, that is a very poor progression. And when you have sperms like that, achieving pregnancy becomes difficult. Now, our lifestyle also affects all this, the sperm quality. Our lifestyle affects the sperm quality, our feeding and medications. Okay, when you abuse medications a lot, and currently we have a lot of people, men also joining women in using bleaching cream and toning cream and all those, they all have side effects. Now, people say they take marijuana because medically prescribed, they can't sleep and all those, but actually these are also having side effects on your sperm cells. And you all know that once we cross 50 as a man, you have lesser intelligent children because the sperm cells become highly fragmented, the sperm DNA become highly fragmented. You give birth to children with lesser IQs and all those. So first step first, go for SFA. When you see the result, you see the physician. They are the only ones who can prescribe medications for you for any form of treatment for semen analysis. Don't say my neighbor said I should take this one, it will work, or I should take Agbo, it will work. It does not work that way. And this one works for Mr. A, it doesn't work for Mr. B. So you have to see the doctor, and any sperm medication that is being prescribed must be taken consistently for 90 days before you can see results, because spermatogenesis happens every 90 days. Sex or no sex, sperm cells will die off in the body. New sperm cells will come up every 90 days. So for us to achieve good sperm count, motility, morphology, viability, progression, we need to put the patient on medication for at least 90 days. Don't know if that answers your question. Thank you, Dr. Heskey.
Okay, thank you very much, Dr. Heskey and Dr. Oji.
I say no. I don't give OG doctorates. Okay, that's a good
Now
one.
well,
So
I
you've
go
heard
soon
it
be
the expert.
PhD doctor.
Yes, so you deserve it, Seth. Okay, so OG has told you everything. Yeah, she's the expert in anything: sperm, cell, ovum, fertility. Seek OG. She's the expert in it. Okay. Now, there's a question I just saw now. Somebody asked of going to the hospital, and then the person asked for a change of antihypertensive medication and was told that he needed to run a kidney analysis test. Please, is this important and why is it needed? Please, okay. Now, first of all, hypertension is blood pressure generally is largely controlled by the kidney. Kidney is a very important organ that controls blood pressure. You understand? If your kidneys are not functioning properly, your blood pressure will never be controlled. You understand? So it is very, very important because it gives us, when we see somebody with hypertension, we always check the kidneys because we want to be sure that the kidneys are functioning properly enough to control that blood pressure. You understand? So that's why it's very, very important, that anytime you're hypertensive and you go to the hospital, at least once a year, you must send for a kidney function test. In situation, if ask for a change of medication, they would also send you for a kidney function test because there are some medications that are safe for the kidney and there are some medications that will not be good for the kidneys. I'm going to explain further. For example, depending on the level there are some people that their kidneys are functioning normal. Their kidneys are functioning normal. It's taking care of the electrolytes. Everything is balanced. Those people, no doctor, the doctors will not be scared of prescribing any type of any type of antihypertensive. Doctor can prescribe for you without any fear of anything. You understand? Now, if they check your kidneys and your kidneys is experiencing some kind of failure, either it's in chronic renal failure, stage 1, stage 2, and all the late stages, especially the late stages. There are some medications they cannot give you. There are some medications that if you take is going to worsen the conditions of the kidney. You understand? And there are some medications that they should give you that will even help the kidneys to continue to have some function or to continue the residual function that is managing to achieve. You understand? So kidney is very, very important in high blood pressure management. Anytime you go to the hospital, they must have an idea of what your kidney function is like, especially if you're treating hypertension. You understand? So that's why I'm sure the person sent you for that test. Now there's a drug, there's some of the kidney drugs that can act, some hypertensive drugs that can actually increase your potassium levels. And high potassium level is not very good for the kidneys too. You understand? Because if your kidneys are failing, it cannot excrete potassium as it should. And if potassium accumulates, it's going to be bad for you. You understand? So they won't want to give you drugs that will increase your potassium level. That's one example. They won't want to give you drugs that will increase your potassium level. So they want to check what is your part of that kidney function test. Potassium is there. We actually call that test, the real full meaning of that test is electrolyte, urea, and creatinine. That's the kidney function test. So it checks the electrolyte levels, and also it checks creatinine, which is a marker, urea and creatinine, which are markers that actually tell us how well the kidneys are functioning. Do you understand? So that's why it's very, very important that it's very important for them to have asked you to do that test, to know how your kidneys are doing now,
to know if the drug you're taking is appropriate for your kidneys, if it's going to hurt you, or to know, as in just to check your general kidney health, which is very, very important for your blood pressure. So that is the reason. I don't know if I've been able to throw more light on that. Yeah. Okay. So, Dr. Eze, you want to add anything to this, what I've just said?
No, actually stated that very well. All the medications that some of the antihypertensive medications are excreted through the kidney. Some medications have to be left excreted through the skin, some go through the lungs and all that, but a couple of them also are excreted through the kidney. And again, if the architecture of the kidney is not in good position, some of those things might seem to be like dumping, residues on the kidney. So it's important to always know what is the health of the kidney. And yet again, some of the antihypertensives are also, like for example, the ones that are, diuretics. The doctor wants to also know what is the state of the health of the kidney before I give you a diuretic. So a diuretic is a medication that you give to treat hypertension by reducing the fluid content in your body. So if the kidney is not in a good state of function, and I give you a diuretic, I'm actually flogging the kidney. I'm flogging the kidney. So I better avoid. If someone has an ailing kidney and I want to place you on some antihypertensives, I will avoid the diuretic because the diuretic is going to be giving the kidney more work to do. So these are some basic technical things that we scientifically do before you go in for that. Same thing happens when you are treating someone on diabetes. You want to be sure that the person also has a good functional kidney. That's why you do the serum, electrolyte, urea, and creatinine to be able to check that the various parameters are in good shape. So yeah, you said it all, but I just wanted to check this. Thank you.
Thank you very much. So somebody is asking a question. Please help us. What is Zoladex? I'm not used to trade names. What drug is Zoladex? So somebody is asking. So
Yes,
how long can?
Okay.
What is the length of what's the length a man of 70 can take Zoladex for, even when the EUCR and PSA are looking good? What is Zoladex?
Well, I think I know Zoladex. We use it in IVF, and I've heard that people for men who are having cancer issues can also use it. But what we use it for is different from what he's asking. So maybe Dr. Heskey can answer that.
Well, for me, with your perspective, OG, for me, any medication that you were given, it is the duty of the doctor to decide when that drug will be stopped or not.
Can you hear me now?
You understand? Yeah, it's the duty of the doctor to decide, where the doctor that prescribed the drug to decide when you are to stop the medications or not. That is why every time you go to the hospital, they always give you follow-up visits. And follow-up visits for you to doctor to know how well you're doing based on medication he or she has prescribed for you. And then they will know when he or she will need to stop the medication when needed. You understand? So we can't be here and be telling you, okay, you have to stop it this time, you have to stop it that time, because we don't know what context that the doctor may have prescribed that medication for you. So if you can throw more light on that, I don't know.
Yeah, so you are right. So it's always left for the doctor who is managing the patient to understand. But I know very clearly that what Zoladex does is to suppress the sex hormones, the testosterone commonly, which is the commonest culprit for prostate cancer. That's why most people, part of what the treatment for prostate cancer is the removal of the testes, orchidectomy. Because if you remove the testes, then the testosterone will not be produced. So, but for people that say, God forbid, I don't want to remove my testosterone, I don't want to remove my testes, it doesn't make me a man anymore, they usually place them on these hormone suppression medications like like Zoladex, which is actually goserelin, and just to suppress those things. The outcome of the effects of the drug is what determines how long it's going to be done. If it means that the PSA is getting better, because there'll be routine PSA done to be checking the level. There are some people that I know very well, and there are some patients I've managed that have been placed on some of these medications. When they come back for their PSA, the value has dropped so significantly. Why? Because the culprit, which is the testosterone, has been so suppressed to the level that it is no more firing the cancer cells. So it's left at the beck and call of the physician. Like we say, we're not here to prescribe and give online treatments. We're only here to give consults, give advice, and refer you to the right channel so that you don't get confused with the services you're getting. Yeah, so that's all I can add on that.
Yeah, thank you very, very much, Dr. Izzy. Okay. Any question? Any other question? Any other question? Okay, so I hope we've been able to answer all your questions so far. Hello? Hello?
Hi.
Yeah. Is anybody raising hands? Okay. In the absence of any question, okay, I want to thank all of you for attending today. I really appreciate the attendance today, okay? Okay, somebody just threw in a question. Yes, said, is it true that malaria vaccine don't they? I think that's the question, yeah? Of course. We currently have malaria vaccine. Dr. Eze, that's your specialty. Please, can you say something briefly about it before we close up
Thank you
today's
very
session?
much. Yes, you've answered it. Also, Dr. OG has answered. Yes, we have malaria vaccine. It's already captured in the immunization schedule for Nigeria. We have a couple of vaccine vials available, but I think right now they have not supplied much more. So it's been captured in the routine vaccination and given to children, I think around the 6th month or thereabout, to boost their immune system around that. The idea was because malaria was one of the leading causes of under 5 mortality for children, and then they wanted to see how we can reduce that to mobility and morbidity. So yes, there is, but I don't think we've gotten enough supplies there. There was just a rollout that was done, and then, but yes, there is. HIV and AIDS, yes, we have PrEP. That's pre-exposure prophylactic medication that has been out there. Just recently, the government launched the 6-monthly PrEP. That is pre-exposure. Before you dive into, if you insist, you must relate, or if you feel that you are in a highly, exposed environment where HIV is so predominant and you want to be safe, you have these PrEP injections that are twice monthly. I think the post-exposure prophylactic medications are still there, but the long-term ones are still being piloted globally. We've not gotten that. But for PrEP, yes, we have it. Yes, and it's quite expensive right now, but I think they're being subsidized in some government hospitals. We have a couple of facilities in Abuja. I think Asoko is one of them that is giving some of those medications,
Okay. Dr. are you
Yes,
finished?
we have those vaccines. Yes, we have those
Okay.
vaccines in country. They might be relatively cheap or free to an extent, but someone is paying for them. Yes, that's my
Yeah.
point. Thank you.
Thank you very much. Thank you very much for your answers, Dr. Zikezi. Thank you, OG. Thank you to all the members of the medical team that online. Thank you to everyone who has attended today's session. Thank you for giving us your time, for asking questions, and we'll hope to see you in our next presentation. Our next presentation, we're preparing something very wonderful for you. We'll be talking on healthy feeding habits. You understand? We're talking about healthy foods, what makes up healthy food, and all healthy feeding habits. That's what we'll be talking about in our next presentation. Okay, that'll be next month. So I hope all of you will be here so that you will know what it means to eat healthy, and also to, when they say, I have a healthy feeding habit, what it means and what healthy food is really, really all about. We'll get to know all that. So I would urge you all to try and make yourself available for next month's presentation, because it's going to be impactful, okay? So thank you so much, and stay blessed. Enjoy the rest of your weekend. Thank you.
Thank you.
Thank you, Mom.
Thank you
Yeah.
very much. God bless you.
Yeah.
Dr. Chika. Hello. Hello.
Everybody don't go.
So that's to end the call be that. I'll call it private be that.